Great, thank you so much. I really appreciate that introduction. I appreciate everybody taking time out of their day to come and hear me ramble. Most of the people that listen to me ramble don't have a choice. Like they're my office mates or something like that. But you guys actually chose to listen to my ramblings, which makes me feel really good. So thank you. Give me just 1 second to share screen, and then I've gotten quite good at the screen sharing these days. Which I shouldn't say before I actually have it going, but it's amazing how Zoom teaches you such things. So this. All right, can you guys see my slides? It's not the presenter view?
We can totally see it. Thank you.
Excellent. All right, so great. So I'm here to talk to you about Envoy Integrated Health, which is a clinically integrated network that's really a collaboration between some of the largest and, in my humble opinion, best quality private independent practices here in Alaska. We'll talk a little bit about why the clinically integrated network has to exists, what its benefits are, who's a part of it, and then why it makes sense in the healthcare system. I was told I could use about 4 or 5 slides, and I am not very good at taking direction, so I've got about 8, but we'll get through them pretty quick. I will also make jokes, and on Zoom, I just assume that you're laughing because I can't tell. It makes me feel better if I think you think that I'm really funny. So there we go. So, I guess I should have said I'm Gene Quinn. I'm a full-time practicing cardiologist at Alaska Heart Institute. I'm also the chief medical officer of Envoy Integrated Health. My background, obviously clinically, is in general cardiology, but I have a background in public health, in healthcare delivery systems, and in quality. So that's me. So why do we need a clinically integrated network? What's going on that pushes us towards having to do this? And a big portion of this, aside from it being the right thing for improving the health of our communities, is that there's a big way that we're changing how doctors are paid. And that's the trend away from fee-for-service and towards what we call value-based care. Basically, this is a continuum with fee-for-service over here and more provider risk over here. And this is really where we are in Alaska. Most of the lower 48 has some amount of your payments and your revenues that's based on quality and not just quantity. And in other industries, that's obvious, right? You pay more for high quality, you pay less for low quality, but that's not really been the case traditionally in medicine. You do procedure X, you get paid Y. You do 10X, you get paid 10Y. What happens to the patient? It doesn't really factor into anything, but that's not really the way that it is in other industries, and that's certainly not the way that everything is headed in the United States. In the lower 48, which is significantly far ahead of us, nobody has a crystal ball, but we can look to them, about 59% of revenue is actually linked somehow to quality and not just quantity. We here in Alaska are behind, and that's mostly the insulation that we get from Canada. Canada is an excellent insulator. It's kind of like down. It insulates us from all of those lower 48 forces. That's also a joke, yeah. So here we are for fee for service. And as you go along this towards linking more things to quality, you start to get for pay for performance. So if you do a good job, you get bonus incentives. This can also mean you do a bad job, you get less money. And then there are things like shared savings plans, budget risk sharing, capitation, or per member per month. And these are what we call alternative payment models. And they even more take on provider risk. The problem here is that you can't just switch from one side to the other. It takes infrastructure. It takes a lot of work to be able to measure these types of outcomes and be able to deliver them correctly. It's not just, oh, we should change the model right now. And the problem is that most people don't have that infrastructure, especially not in Alaska. In Alaska, the market is pretty fragmented. There are a lot of individual private practices. Most doctors are not employed by a health system. We don't have a Kaiser here, and they may do an excellent job within their own silo and within their own clinic. The problem is that patients don't stay inside the clinic. They go home, they may go to the emergency room, they may go elsewhere, and they may go to other practices that are outside of that silo. And so the coordination of care gets decreased, right? You're not really coordinating true quality across these different specialties. In the lower 48, what's happened is that health systems tend to be the only ones that have the infrastructure for quality and value and for measurement and everything like that. And what that does is it drives physician employment and consolidation of health systems, as well as what they call vertical integration, which is a term from supply chain management that just says if you are creating something and you want to have all of the components of that, all of the supply for that, then you buy it. And that's a term, or that's what health systems will do with primary care providers, is that they are where all of those components for surgeries and hospitalizations are, so they purchase that, and that's vertical integration. If you're a doctor and you hear that called that, it kind of gives you prickles, but that is a common term in business, right? So, well, that seems like not so bad, right? The consolidation, maybe that's better. The problem is that there's a lot of evidence, and Atul Gawande and lots of people smarter than me have written about it, that hospital consolidation and physician employment and vertical integration actually lead to no better quality, but definitely higher costs. So this is that other option, and especially when you have health systems that don't necessarily talk to each other and don't want to or are competitive, if both of them start to consolidate, then you have less provider communication, you have decreased access, you have decreased quality. That doesn't really make sense to us. So what makes sense to us is that instead we start to draw lines between the provider groups themselves so that we can coordinate care. Everybody still stays independent, they're still their own practice, but and they still run their own ship. Everybody gets to stay independent, which is a very big Alaskan physician quality, but we can still come together for some things like coordination of care, like improving quality together, like being able to have different protocols and best practices for different disease conditions across different specialties, et cetera, et cetera. And what that does is it builds that infrastructure, that shared infrastructure, to be able to do quality, to be able to do value, and to be able to do public health together with the CIN. And that's what Envoy Integrated Health is that that shared infrastructure that gets to integrate all of those different practices while still letting them enjoy their autonomy that physicians like. And in that system, it looks more like this. Instead of being a big line, you've got a clinically integrated network that has providers that practice at one or the other or both. I personally am licensed and have practiced at like 5 hospitals in the state, and many of us do go across them because it's a small state. There's not that many cardiologists, there's not that many doctors. So really, when the locus of that coordination of care is with the independent physician groups, then you can get better quality. You can have the platform to be able to improve the population health, to be able to work on things like vaccines, like chronic care management, like cancer screening, like all or many of the things that are a part of the Healthy Alaskans 2030 initiative. And that's really the goal, is that when 2030 happens, I think it'll still happen. COVID's not fun, but 2030 will still happen. I hope personally that they say, here are the things that we've achieved success on, and boy, Envoy helped us. So that's really what this is. It's a network that enables these high-performing practices to work together, have shared goals, be reimbursed for it in a value-based way, but still be independent, not have to share finances, and really with a quality and public health mission. It's not intended as a profit center. Is there revenue that happens? Absolutely, but that's a side effect of doing a good job, rather than the point of it being to get market control or to get profit, and then, oh, maybe quality might happen later. So who are the members of this? I'm going to boast, but you're a captive audience, so you get to listen. It's some of the largest and some of the most well-respected practices in the state. This is OPA and AFOC, so both of the large orthopedic clinics, Latouche Pediatrics, Alaska Heart and Vascular. We have the GI docs, that's IMA and Alaska Digestive and Liver Disease, Peak Neurology, ENT specialists. We've actually, this is an old slide, I keep having to update it. We have about 13 practices so far, and I would say maybe 10 in the pipeline. And then we also have the ability to partner with like-minded organizations. You know, we're interested in improving the health of the community that where we live and work. My kids go to school here. I shop for clothes at the same place as every Alaskan, Costco. This can really be a platform for public health and population health in a population that's often not thought of, right? Which is the private practices. Private practices traditionally haven't really partnered with state organizations. Tribal organizations have, FQHCs have done a good job, but we as private practices haven't done a good job of that. But now we work with the state of Alaska on tobacco cessation and on other types of public health problems that we're both interested in. We also have the ability to collaborate for patient safety, more coordination, the less medical errors. We work with MIEC to be able to build some of that infrastructure. We also want to be active participants in healthcare reform. One of the ways that we can leverage data and leverage infrastructure and leverage interoperability to do that are things like health information exchanges. We could have built our own, and oftentimes people do build their own health information exchange around the CIN. But again, we were talking about how there's a difference between doing a CIN for market share, and oftentimes when you build your own, you're trying to say, this is my data, I get to use it for my own purposes. Really, the purpose of interoperability is to have everybody have the amount of data that they need to take care of the patient at the site of care, as well as be able to leverage that data to do the population health, the screening, the hypertension, et cetera, all together. And so we found Healthy Connect with its nonprofit, neutral, and state legislated health information exchange, an excellent partner. We're actually together working on both having more physician engagement in the health information exchange, as well as helping them to build the population health aspects that we could finally leverage here in Alaska. So that is that's really the overview of everything. I have about 40 more slides, but I'll try not to go over those now. Instead, I'd just love to hear feedback, take questions. You guys can ask me anything, and I may or may not actually answer you. No, I'll definitely answer. Just joking.
So thank you, Jean. That was an awesome presentation, and I loved all the slides. So thank you for all of that. I guess one of the things that I'm most excited about is to see that communication between different practices, and also between like the state of Alaska and other organizations. It seems to be the key issue that many patients have, is trying to get their various physicians to actually speak. I, of course, always have questions, but if you want to maybe stop sharing your screen and we can kind of see the other participants, is there anybody else who is online that would like to ask a question? I'm going to pause for a minute and see if he or she would like to do that.
So Jacqueline, this is Sandra Heffer, and I'll go ahead and start. So Dr. Quinn, you talk a lot about the coordination of care and moving more towards a value-based kind of a model. Do you anticipate that the CIN will see a reduction in cost, whether that's cost to individual patients, to the healthcare system as a whole, to the state of Alaska, et cetera? And then kind of my secondary question is the Center for Medicaid and Medicare Services, their Innovation Center, came out a couple of weeks ago with a list of their different models that, kind of their alternative payment models that have actually realized statistically significant savings. And just wondering how the CIN model fits with what those recommended models are.
Yeah, absolutely. Those are Good and very easy questions, as I would expect from you, Sandra. No, I'm just joking. They're very, no, those are excellent and they're very important. Let me tackle two. So when we talk about cost, and we talk about value, oftentimes people say cost and value is the same thing. Obviously, they're not. What value is the amount of quality that you get per unit cost. And so you can improve value by either improving quality for the same amount of cost, or you can decrease the cost with the same amount of quality, or you can do both. I do expect that this will overall reduce the cost of healthcare, or at least it is certainly one of the mechanisms to do it. And there's a lot of different levers that you can pull in terms of doing that. And actually the CIN is set up to be able to have many levers at its disposal. So you can not just work on one thing, but you can work on readmissions, you can work on waste, you can work on operational efficiencies. Like we can do less testing because we're not having to repeat tests when people come from NOM and Medicaid is, and possibly Medicaid or possibly themselves has paid for them to travel here. And oops, I forgot my test up there. Well, sorry, do I send you back and then bring you back again in a couple of months, or do I repeat the test? I'll tell you that both of those things definitely happen. So there's a lot of that we can do. We can also make sure that people are getting care in the correct site of service, so they're not always having to go inpatient. They can go to ambulatory centers, et cetera, et cetera. So I definitely think that that this is a huge step towards decreasing the cost of healthcare. It's a very multifactorial thing, obviously, and I'm not going to say that this is the only piece that needs to change. And it also takes willingness from a lot of different stakeholders. It's not just me, it's also the payers, it's also, and that's both governmental and private. There's a lot of people that have to all come together and say, yes, we want to actually improve this, and this is the way to do it. So I guess I could have just said, yes, we're the secret sauce, don't worry. To your other point, we're absolutely set up to for some of what the CMS's innovation centers have said are best practices, and in fact, better than some. When you look at a lot of the ACO data, some of those ACOs don't actually do very well in terms of either quality or cost reduction. The ones that tend to get the most cost reduction actually tend to be the ones that are run by physicians and not necessarily sponsored by health systems. And there's a lot of theories that I have about that, but we definitely know about that data, and we definitely think that we are the correct model to be able to bring that data to life in practice. Great questions. You're smart. A lot of smart people here.
That was an awesome start, Sandra. Thank you so much. Are there other questions? You're welcome, Sandra, to follow up, or if there's anybody else.
You won't get another compliment, though. Only one compliment per question.
I would get a compliment if I use the word infrastructure.
That's what it's all about. That is my, Sandra will know that that's one of my pet words, and that's because I live and breathe practicing medicine here. And what I see what I don't see in Alaska that I may have seen when I was at a 1,000-bed hospital that was connected to another 1,000-bed hospital that was connected to another 1,000-bed hospital that had 15 layers of administration is infrastructure. And if you just flip the switch and say you are now doing value-based care and you don't have the infrastructure, it'll all fall apart. But we can build that infrastructure. We just have to build it together and build it in a way that supports patients and supports providers. Because frankly, there's not an unlimited supply of doctors that are willing to move to Alaska, and that's because they don't realize how awesome Alaska is, but we got to get them to come up.
I had a question. I'm really curious. So are medical providers or healthcare providers generally eager to join? Is there a lot of hesitancy? I mean, you have some of these top providers. Have they jumped on board? You know, what's that taken, and what's the general feeling?
Yeah, that's a good question. So I will say yes and no. The people that have jumped on board are very enthusiastic and very engaged. I said that I have 13 groups, but I've probably talked to 40. There are definitely some that have dropped off along the way, and maybe not as excited, and that's okay. There are, like any change management, right? There's first followers, and then there's the Luddites at the end. Usually, and the great thing is that it will become at some point, and I think that we are very close to, if not already there, with the critical mass, that it's actually less normative to not be a part of something like this than to be a part of something like this. But this was a long process. We spent, I've been here for 4 years. We started a little bit about 6 months after I got here. So, and then have ramped it up. So I would say this is a 3-year process with a year plus of talking with people and together building the structure and governance of everything like this. So it takes a lot of trust building, but I have not heard anything but enthusiasm from the partners on the board, and it gives me a lot of hope. So I think it's going to be great. Good question.
Thank you.
But the other piece of that, though, is that we are 100% physician owned, 100% physician run. And I think that that's actually really important, is that physicians want a voice and they don't want to be told what to do. Now, they may actually come up with the exact same thing that you would have come up with, but they don't want to be told it. And, you know, some of us, there are a lot of parallels there that I won't make fun of physicians about, but you can do them in your own head.
That's awesome. So one of the things that we always like to ask, and we have about 5 minutes left, happy to stay on if people still have questions, but what can we do for you? So one of the things that this group likes to do is promote these great innovations and, you know, just help you meet your mission. So how can we help you?
Yeah, that's great. Well, I appreciate it. 3 things, I guess. The hard one that you guys don't need to do, and that's my part, is that we're always looking for new members, especially people that are interested in doing the very best quality that they possibly can. But that's my job. I can proselytize the doctors. What I would really be excited about, if there are groups out there that think that they may have a similar mission around improving the quality of care that's delivered, improving the value of care that's delivered, and especially they have public health interests in general, and think that Envoy might be a great platform to work together, we'd be happy to kind of to explore those partnerships, and we're actively doing those things. So that's so if anyone wants to talk about that, you can definitely look at or you can definitely email me. You could also go to the website, and I think there's some sort of thing. It's envoyintegrated.com or envoyak.com. And then the third one is I think, you know, just be engaged with the types of things that that matter to you, that would support the same thing. I'll say that I'm also a board member of the Health Information Exchange, Healthy Connect, which is really taking some awesome strides right now, and has been on a big upward turn to be able to do a lot of different things. There is a lot of untapped potential there. So if there are things that you want to achieve with the Health Information Exchange, that's another thing that, you know, it is a nonprofit, so it always needs your support. But I think that those are the big things that you can do to help me. And ask me easier questions. No, I'm just joking. Your questions are awesome. I'm just joking.
This has been an absolutely wonderful presentation. What I'm going to do is I'm going to put a copy of your website into the chat and invite people. I think the most important thing as a consumer of healthcare is I don't think patients know about these differences. And, you know, perhaps at another time, or maybe at the upcoming state of reform conference, one thing that I'm interested in is how can this message be shared with patients so that they understand the difference between fee-for-service and value-based care, and why value-based care is different. So at any rate, I think that's something that all of us can do as patients, is maybe talk to our physicians about that and about how we understand the difference. But thank you very much for your time today, Dr. Quinn. It's very exciting to see this development. And the next step that we're going to do is I do something called the Director's Minute, in which I kind of tell people about our latest updates and things like that. You're welcome to stay. A lot of people slip this in right after lunch and drop away after 1:30. So everyone's welcome to stay who can, but then that'll be our next step. So thank you for coming. Can everybody give Dr. Quinn a virtual round of applause, and thank you again.
Thank you very much. It's really an honor to be here. I appreciate it. I would love to talk about consumerism in healthcare and how that how market forces can work for healthcare, but maybe not in. It probably takes me more than 60 seconds to do it, so I'll let you guys go. That's a fun one.
Well, thank you so much, and it would be lovely to have you back another time. So thank you very much, and we could do a deep dive then. So thank you.
And guys, I really appreciate it.